Thank you very much. I've lost the slide. There it is. Thank you for the invitation to speak. And I have to say, I'm absolutely delighted to see so many people here, particularly patients. I think meetings like this, as Professor Gilmore indicated, are super important. I've been tasked with speaking about wild-type amyloidosis in clinical practice. What we haven't seen today are any disclosures from people, and when I make these, I may be asked to leave the stage, so it could be a very short talk, but you've heard most of it already. My first important disclosure is, until yesterday, I had no idea where Gweedore was, but that's been clarified on this morning's slides. And also, until yesterday evening, I had absolutely no idea what splitting the G meant. If you're unaware, you can go to the Heart Failure Warrior stand, and Nicole McKelvey will educate you in what splitting the G means. So provided you're all happy, I will continue talking. And my aim is, I suppose, to try and not bore you with statistics and what we can and can't do, but to maybe make patients in particularly aware of the difficulties that clinicians can have in reaching the diagnosis, and some of the steps that I think are critically important for us moving forward in time to try and improve the care that we can deliver to patients and help educate other professionals. And I've been asked a number of times, well, you work in Craigavon, how often do you see amyloidosis? My comment has been the same to every person. It's there. You just need to look for it. And if you look for it, you will find it. The majority of my patients are AL amyloid or wild-type TTR, and that's very different to Sinead's, I'm not sure where she's gone, who has predominantly hereditary. So why is it difficult? And I need some audience precipitation to maybe demonstrate this, or you'll think I've gone completely crazy. So if I was to ask you to describe a rhinoceros to me, what would you just shout out some things that would help describe a rhinoceros? A horn. A horn? Well, a stag beetle has a horn, and so does a unicorn. So we might need more than that. Scary. Scary. Big. Yeah. So there are lots of descriptors that we could use to apply to it. And of course, if we apply them and have a simple picture, there might be something else in the picture which isn't quite right. So we maybe need to narrow down our descriptive terms sometimes. So if you were to describe a human and apply maybe slightly better descriptors, what would that be? One head? Yeah. Anything else? Two legs. Yeah. Two arms. Yeah. So again, we can apply that. I maybe have gone a wee bit off track, but the point is, if we apply very, very basic descriptors and look very superficially at images, you'll not get it quite right. And to me, amyloidosis is exactly that. It's there, but we need to apply a forensic level of detail to our clinical assessment, so listening to patients and what they're telling us, looking at the basic investigations that we have in front of us, and then looking at some of the more detailed investigations. And for people who specialise in amyloidosis, it's easy for us to spot them. They jump out, they're there in front of you, you know it. But for people who don't, that can be very challenging. Oh, this thing, again, isn't working very well. So amyloidosis really is a disease that is hidden in plain sight. So the identification in clinical practice can be really, really difficult for loads of reasons. Lots of people are unaware of it, so they heard about it in medical school. They think it's exceptionally rare, and they're never going to see a patient with it. So they don't have an understanding, and if you don't understand something, you're not going to know what to look for. If you showed that picture of the rhinoceros to a 2-year-old and they'd never seen one before, they would think all rhinos had a head at the top and bottom, but of course we know they don't. Also, medical profession is quite guilty of working in silos. Professor Joyce indicated that earlier. The amyloidosis strategy for Ireland was to try and pull things together in a hub and spoke model, getting multiple specialties talking to each other to try and get the right diagnosis for patients. But as I'm sure many of you have had in your journey, you've maybe seen the GP, you've seen a gastroenterologist, maybe a neurologist, maybe a cardiologist, and it takes a while before the penny drops somewhere. If we all work together a wee bit better, hopefully that journey would be a lot faster for people and help you reach correct diagnosis earlier, because misdiagnosis is very, very common, and we heard that earlier, even from people who specialise in neurology or cardiology or nephrology. Sometimes you get it wrong, and it takes a while before you think, you need to go back and look at things and get this entirely right. One of the things I absolutely hate hearing is, oh, it's because I'm getting old, or oh, it's because you're old. Well, we heard earlier that senile disease is when you're 64. Of course, that's not true. What can you attribute to getting old? Because we all know people that are 96 and fit as a fiddle. We all know people that are 50 and are pretty wrecked. So I think you can only attribute things to getting old if you've absolutely excluded any potential pathology. That's one thing I don't like. There is a definite lack of resource, and we've heard that multiple times today, and I think it's really disappointing. Ireland is, it's a small country, no matter how big we all think it is in our heads. It's very small, and it's a small population. And if you look at what we have available on the island of Ireland for amyloidosis, there's inequity for patients. So if you live up in Craigavon, thankfully you're able to get DPD scans. If you live in Donegal in the south of Ireland, you have the opportunity to go to the Mater Hospital and have expertise there. If you live in the rest of Northern Ireland, then you maybe see someone who might have a wee bit of knowledge. You might come to a centre where someone has a bit more interest or specialises in amyloidosis, but you still then have to go across by plane to England. And of course, lots of our patients are very frail, even at a younger age, because of their condition, and that's simply not on offer to them. And of course, until recently, I was having conversations in clinics saying, I think you have this, I think you have wild-type amyloidosis. Would you like to get on a plane and go across and meet the lovely team in England? Oh, yes, doctor, does that mean I'll get treatment? Well, no, because there's no treatment because you don't have polyneuropathy. Thankfully, that's changed. That is improving, but lack of resources is still something that is preventing us highlighting amyloidosis within our populations, getting all clinicians interested in it, and then reaching appropriate diagnosis. In 2021, I set up a rapid access heart failure clinic in Craigavon, and I promise you, my hand on my heart, this is the very first patient who presented. So my writing's the lovely, very legible writing on the bottom. The top is not so legible, that's an orthopaedic surgeon. 2014, I can't read it from here, so I'll have to go off memory. I think it says day 1, carpal tunnel release, warfarin home. Down below then is mine, not much more detail in it. 90 at this stage, so 7 years down the line, referred from the GP, short of breath, BMP over 2000, history of carpal tunnel, renal dysfunction, atrial fibrillation, hypothyroidism, previous angioplasty. You'll not be surprised to learn what the diagnosis was, wild-type amyloidosis. The point being, again, clinical indicators there from before. If a flexor retinaculum sample had been sent in 2014 with the carpal tunnel release, the diagnosis may have been made then. I am pretty sure this patient had symptoms before the age of 83, because in Northern Ireland they probably waited about 7 years or 10 years for their carpal tunnel release. So there was definitely an opportunity to intervene way earlier if people had just been aware of the clinical signs and symptoms that would point towards this rare, but maybe not so rare, disease of wild-type amyloidosis. So I think it's really important that we try and reframe our clinical practice to lead to better outcomes for patients. That's our whole job as doctors. All we're here to do is treat patients, make you feel better, and get the right diagnosis. So to do that, we need to fully understand the disease, and thankfully a large number of teams have made massive progress in understanding the disease, its pathology, the treatments that are available, and developing treatments. So that is improving. We need to ensure that clinicians understand some of the clinical clues, either in the symptoms, signs, or basic investigations that patients get that would point towards amyloidosis. Really importantly, we need to understand it's a multi-system disease. Often people come to the cardiology clinic, for example. I'm a cardiologist. They're busy clinics. You come in and you get asked specifically about your cardiac questions. And I'm sure some of you have said, you've probably been in the position where you've seen a specialist and said, oh, but I also have, I'm a gastroenterologist, you need to speak to your GP about that. If people follow that, you'll never make headway. When I see a patient and their heart failure signs and symptoms, I always ask about the rest of the body. I think it's critically important. It might alter some of the medications you give, even if it's not amyloidosis. But if you don't ask, you won't find those other clues that make you think there's something else going on here. If you don't ask, you won't get. We need to broaden our horizon a wee bit and retrain the way we think, like those images at the start. If we don't apply a forensic level of detail to our history taking and the way we read and look at tests and investigations, of course you're going to miss it, because the majority of patients who come to my clinic with heart failure don't have amyloidosis. That's fact. But a lot of them do, only if you look for it. And really importantly, and there is traction on this, I think we need to start setting really good standards of what good care is and how we should monitor and follow up patients with amyloidosis. And that should be something that is equal to every patient with the condition across Ireland and the UK. And we are making improvements in that. You've seen this already, so I'm not going to dwell on it. What is wild-type amyloidosis? We've heard already. It's a misfolding of a tetrameric protein. And then because of that, it kind of just aggregates in organs, and the heart being the common organ for wild-type amyloidosis. You heard earlier that other types of amyloidosis where that protein can aggregate in other areas, and kidneys, for example, where it kind of clogs up your kidneys and stops them working very well. It's more common in men, and we heard very eloquently this morning, if you live long enough as a man, there's two things you're going to get. Prostate cancer is one of them, unfortunately, and the other one is wild-type amyloidosis, and that's true for every human. If we live long enough, you will get these conditions. 85-year-olds, about a quarter of them, over the age of 85, have wild-type amyloidosis. They may not be symptomatic of it yet, but they certainly have features somewhere in their investigation pathway. Professor Joyce indicated earlier we ran a prevalence study. It started in 2018. It was an undifferentiated HFpEF population, really loose description. You had to have heart failure symptoms, an abnormal BNP, and your atria had to be dilated. And with those three basic things, 8% of the population that we screened were found to have wild-type amyloidosis. And that's only the tip of the iceberg. And as I said, it does have a cardiac predominance. What other difficulties are there? Well, I think we've already explained this a little bit, but it can masquerade as other things. It is there, but it's often misinterpreted. And I can certainly remember retrospectively as a registrar the number of patients where the echo's been a bit funny, you know, the heart muscles being bigger than normal, and they probably had amyloidosis, but the answer I was given was, sure, they've got high blood pressure. And your heart muscle is like any other muscle. If you put it under strain and ask it to do more, it thickens up. So lots of times other teams would see this and say, oh, well, they've high blood pressure, it's hypertensive heart disease. Or it gets misdiagnosed as other conditions, sarcoidosis, Fabry's, aortic stenosis. We call some of these infiltrative diseases. So sarcoidosis is an example of that, where stuff invades and fills the heart muscle and makes it thicker. But if you don't apply the right diagnostic pathways and right questioning, you'll not reach the diagnosis, because each of these has slightly different subtle features in the history that you'll tell the clinician, in what we will see when we examine you, and then what we'll see when we look in detail at the imaging that we have. So that, you know, I'm sure some of you have probably had these diagnoses given to you incorrectly. I'm seeing one head nodding at least. That's unfortunate, but good, because it's highlighting my point. So this is often what happens, and you're going through this cascade. And what's it doing? Well, it's getting the diagnosis wrong, but importantly, it's delaying treatment for you. And we've seen really clearly this morning that early introduction of treatment makes for better outcomes. So we need to encourage people to do this better. I think Professor Joyce, screen's gone down at the front, showed this slide earlier about misdiagnoses. HFpEF, so heart failure where the heart's pumping normally, about 13% of those patients have wild-type amyloidosis that we know of. HFrEF, so where it doesn't pump so well, nearly 10%. So, you know, 1 in 10, you know, that's quite high. So it can masquerade. Conduction disorders, I put a lot of pacemakers in, and often these patients come up for the pacemaker. No one's ever thought about amyloidosis. And it's only when I'm putting it in and then looking at their other investigations and thinking, there's something not quite right here. Get their pacemaker, but then they need to come back for the amyloidosis diagnosis. I forgot to mention at the start, disappointingly, it's exceptionally rare, and Sinead agreed with me earlier, it's exceptionally rare that I get a referral saying, I think this patient has amyloidosis. Most of mine are picked up incidentally because they come to my clinic, and I see them and I think, this is a bit worrying, or I'm putting a pacemaker into them, or thankfully we have physician associates now in Northern Ireland, and they're like sponges, they just love learning, and they really listen, and they've actually picked up a huge number of patients on the ward and said, listen, would you mind taking a look at this person? It's not adding up, I think they have amyloidosis, and they've usually been spot on. And that's by applying some of the basic principles that we've taught them about clinical signs and symptoms to look for. And you've heard of these earlier on today. So things like carpal tunnel syndrome. Of course, just because you have carpal tunnel syndrome doesn't mean you've got amyloidosis, but there is certainly an association with it, and particularly if you've got it on both sides. More specific things that can indicate ATTR amyloidosis or bicep tendon rupture. I remember very clearly seeing the first patient ever that I saw with this. I was a junior doctor, and I thought this guy just had massive biceps, but it wasn't his bicep tendon and ruptured, it falls down, so it looks huge. So that is associated with ATTR, as is spinal stenosis. The incidence of carpal tunnel, well, you could get an answer varying between 1% and 40%, depending on what paper you read. We know there's an association. So if we apply those principles, we look at our patient cohort, we apply some of those red flags, it should be making people think there's maybe amyloidosis here. And some of the other things are sitting there, again, in plain sight for you to clearly see. So we see ECG abnormalities, but of course you see these anyway. Just because you have atrial fibrillation doesn't mean you have amyloidosis. But if you've got this, you've got some of those subtle clinical signs on examination and some of the information you're telling us, everything's starting to stack up and maybe move you away from thinking this is high blood pressure to thinking there's something else going on here. Echo has some, again, characteristic features, but not 100% specific. MRI is exactly the same. And two that I think are underutilised in day-to-day practice are troponin and BMP. So troponin's an enzyme that's released in your heart, most often checked because people think the patient may be having a heart attack. Basically, everyone who comes to A&E, if you stub your toe, you can almost guarantee you'll get a troponin and get a referral to cardiology. But what you see in amyloid patients is that they have a baseline elevated troponin, and they usually have BMPs that are vastly out of keeping with the level of symptoms that you have. So the BMP is significantly higher than you would anticipate for the level of symptoms that you're presenting and telling us with. And that's, again, when you add it into all the other bits and bobs, I think is a red flag that should make people think there's something else going on here. I think I went backwards now, so I better go forwards. So these are all the red flags. We apply them, and then you undertake the workup. And this has already been explained earlier, so I'm not going to dwell on this. But it is actually pretty simple. The team in England have a beautiful algorithm. We no longer need to take biopsies for the majority of patients. Why are we not keen on doing it? Well, I think it stands to reason that going into your heart and taking a plug of muscle out, is relatively high risk. We can do it, and we can do it safely, but we prefer not to do it if we can get away with it. So we have these non-invasive strategies, so things that we don't need to go in and pull stuff out to reach a diagnosis, largely entailing bloods. So within Northern Ireland, I can do all the bloods. And the important thing for me when I'm seeing the patient is to exclude AL amyloidosis first of all, and I can do that almost exclusively with bloods. Not all the time, as we've heard earlier. There can be complex crossovers of a patient like that at the minute. But that will help determine which pathway they're going. Is it going to be chemotherapy for a light chain amyloidosis, or is it going to be other therapy for an ATTR amyloidosis? And then we need the access to DPD scans. And for me, in the Southern Trust, that means the patient has to fly across to England at the minute. A DPD scan is cheap. The tracer is cheap. We have the scanning facilities, so it's the same bone scan that people get for cancers or for sarcoidosis, but it's not funded, unfortunately. So you're all aware that government decisions can sometimes be a little bit unusual, but they seem to think that it's better to pay to send someone across to England than it is to pay a small amount for a tracer and have it here, which is a bit disappointing, but it is what it is, and we have to work with the system we have. Hopefully that will change. So thankfully, as I said at the start, a couple of years ago, if you had wild-type ATTR amyloidosis, that's tough. Have some diuretics. There's not much else we can do. Thankfully now, we have access to treatments, and you're aware tafamidis has been approved and is available through NICE. But in Northern Ireland, nothing's ever simple. It's not just that straightforward. So first of all, to get to England, we have to fill a whole host of paperwork in, and they have to agree that you need to go to a specialist centre for assessment of a disease that we can't diagnose in Northern Ireland. Then, even though the team say, yes, give this patient tafamidis, we have to submit a cost per case analysis for each patient to get approval to supply it. Your GP, we can't just say to the GP, listen, can you give that patient tafamidis? That just doesn't happen. So that does, again, cause just a little bit of delay in getting treatment for patients, but thankfully that's massively improving, and certainly recently I've had quite a large number of patients easily transition across onto tafamidis, so that's a good thing. Things are improving. What other considerations? We heard earlier, Kathy, I think it was, explained about the management in the community. Volume management is really important for amyloidosis patients. Sitting in a hot room after having some free beer or drink last night is like the ultimate test for your autonomic system, and I'm shocked that none of us, whether we've got amyloid or have not passed out yet today, because this is the ultimate test. Volume management is very, very important. As you're aware, you're very sensitive to changes in volume, and that can be dehydration, which can make you feel terrible to the point of collapse, but it can also be overhydration, where you start to accumulate fluid. Fluid restriction and diuretics have an important role. There is some evidence to suggest that the SGLT2 inhibitors may be beneficial. And then we run sometimes into problems, particularly as disease progresses, that standard heart failure therapies are no longer tolerated. Things like beta blockers. I explained earlier that often patients need pacemakers. You've heard about that a lot, and that's because the electric system in the heart's starting to wear out or be affected. Beta blockers slow your heart rate down. That can often make things worse. Similarly, drugs that lower your blood pressure can also make things worse, because as you're aware, your blood pressure can often be on the lower side or certainly be very fluctuant. But we do have strategies to combat that, so adequate hydration, and as Kathy explained earlier, drugs like midodrine or fludrocortisone, which work reasonably well, and I'm sure some of you are already potentially on that or have been on it in the past. The monitoring, I think, is really important. It's very, very difficult. An NHS 6-month review, as most of you know, usually means about 2 years. But what we should be doing is seeing people regularly to assess their symptoms and look at some basic tests. So we can look at biomarkers. Is the BNP elevating? Is the troponin elevating? Are there subtle changes in the echo scan or the ECG that indicate potential disease progression? And if so, what rate is it progressing at? Do we definitely have you on the right treatment? Do we need to go back to our experts in England and say, listen, things are progressing. Is there anything else we can do here? Unfortunately, as most of you are aware, timeframes push out. Now, the team in England are brilliant at keeping to their timeframes. Locally, unfortunately, I have to hold my hands up and say that we're not just as good, but it is something we should strive to. So that's where I'm going to end. In summary, there are red flags there. Whilst it is rare, I think it's actually easy enough to spot if you just know what to look for. It is hidden in plain sight. There are lots of things that point towards it. These are more for clinicians. If they see these, everything's kind of stacking up to it not just being high blood pressure, maybe being something else. I do have one more slide. I have no idea why I put it in. I think it should have been way earlier, but I forgot, and you can't even see it because it's not letting me get to it. So I will end there.